Madam Sinha, Professor R.N. Srivastava, Professor Vivek Jha, distinguished delegates on the dais as well as audience and dear friends. It is an overwhelming occasion for me to be honored for this oration. Professor Sinha has left a legacy, and as you can see, some of the biggest names in international and national nephrology have been his students, and I've had the privilege of interacting with him when he was the president as well as the secretary of the Indian Society of Nephrology. So I'll be sharing with you my experience in managing kidney disease in kids over the last 3 decades or so. But first of all, to start with a quote from none other than late Nelson Mandela, that there can be no keener revolution of a society's soul than the way in which it treats its children. Because after all, children are the future of the country. So during my tenure, I have looked at the problems of UTI in children, hypertension, nephrotic syndrome, acute kidney injury, crescentic glomerulonephritis, chronic kidney disease, CAPD, kidney transplant, some management during the COVID, and also some role of telemedicine, and be touching briefly on some of those. So we started by looking at UTI in children and highlighted how they are important, not only in children but also in nephrotic syndrome, triggering relapses, in kidney transplant patients, and also the role of DMSA scans in following up these children for incomplete resolution and progression to chronic kidney disease. Hypertension was another area of work, and we looked at malignant hypertension in children and how aortoarteritis was an important complication. The spectrum of reversible posterior leukoencephalopathy in these children, and we highlighted certain atypical findings. Also, this was that resolution is not always complete. Nephrotic syndrome has been a particular area of interest for me, inspired by Professor R.N. Srivastava, who was my examiner during my MD at PGI Chandigarh. And these were several papers that we looked at, looking at the steroid response pattern, looking at intravenous cyclophosphamide, treatment of children, the need for awareness, especially in the general community, spectrum of infections, and we highlighted that UTI and tuberculosis are 2 important infections besides peritonitis in these children. We looked at FSGS, duration of optimal therapy, factors predicting remission in steroid-resistant nephrotic syndrome. And this is some of our work which has been recognized at the international level. Indications for kidney biopsy, we identified certain novel trends in histopathology highlighting the increased evidence of prevalence of FSGS, how again steroid-resistant nephrotic syndrome, the histopathology is changing. 2 treatments, intravenous cyclophosphamide and tacrolimus, which we were fortunate enough to publish from SCPGI and form a part still of the 2021 IPNA guidelines, bone diseases and nephrotic syndrome, and work on genetics. But first of all, this was a paper which was published in Pediatric Nephrology 2002, and we re-looked at the guidelines in light of our experience, and we said that it's time to revise these guidelines, and kidney biopsy should be restricted to children whose nephrotic syndrome is under 1 year of age, if they are not responding to 4 weeks of prednisone, unusual clinical or biochemical features, and if you are using cyclosporin. And this was an editorial in the same issue of Pediatric Nephrology, where the IPNA said that yes, it's time to revise the guidelines. This was followed by a consensus conference, and it indeed resulted in a change in the guidelines, and biopsies were no longer done in frequent relapsers, steroid-dependent children. This was another seminal paper on the changing trends of histopathology in childhood nephrotic syndrome, published in American Journal of Kidney Diseases. So what we found was that over 2 different time periods, as you can see, the prevalence of focal segmental glomerulosclerosis had increased. This was also quoted in a paper by Eddy and Simmons in Lancet 2003. Studies from different parts of the world, Saudi Arabia, North America, USA, including our study from India, showing that over those 2 different periods, the prevalence of FSGS as a cause of nephrotic syndrome had doubled, again telling us that it was no longer as easy to manage as it was earlier on. Again, the cause for this needs to be identified. This is a paper published on looking at the spectrum of histopathology in steroid-resistant nephrotic syndrome, published in Indian Pediatrics 2006. We compared our data of 136 steroid-resistant children with 103 for the ISKDC study. So similar findings here, that the prevalence of FSGS had nearly increased 3 times. The mesenteric glomerulonephritis was coming down because of the infections. Again, minimal change remained an important component, but again, FSGS was an important component. This was our landmark paper, a randomized controlled trial of intravenous cyclophosphamide in steroid-resistant minimal change disease. So mind you, this was done in 1994, and at that time, there was very little that we could do other than use oral endoxifen. So in this paper, we compared intravenous cyclophosphamide with oral cyclophosphamide, and what we found was that not only there was a significant improvement in the remission rate, but it also the remission came at about a 40% lower dose. And this again has been highlighted in the 2021 IPNA guidelines, and as recently as 2021 paper by Lavjai Bhutani also, this paper, protocol has withstood the test of time and remains one of the important therapeutic protocols in management of steroid-resistant minimal change disease. This is a similar protocol that we used in steroid-resistant FSGS, a higher dose of 750 milligram per square meter, a definitely lower remission rate than what we observed in minimal change disease. Not surprising, because this was a mixed bag, and I'm sure a subgroup of these FSGS were genetic FSGS. We also found that it was far more economical than the innovator brand of cyclosporin, which was all we had. So, at least in our patient population at SUPGI, majority of them could not afford cyclosporin, and response was better in secondary steroid-resistant nephrotic syndrome. We also used a similar protocol of pulse cyclophosphamide therapy in 2 different subgroups of steroid-dependent and frequent relapsing subgroup nephrotic syndrome, and what we found was that responses were very good. There was a 42% complete remission rate in the steroid-dependent group. There was about 31% improved and became infrequent relapses. Another 17% were frequent relapses. Only 10% continued to be steroid dependent. In frequent relapses, this was even better. 68% of these attained complete remission, 18% frequent relapses, and 14% continued to be frequent relapses. And this work on intravenous cyclophosphamide was recognized by the Indian Council of Medical Research. This is our work on tacrolimus, a new therapy for steroid-resistant nephrotic syndrome, which was among the first few studies from all over the world, and till today this remains one of the most optimal therapies for steroid-resistant nephrotic syndrome. 22 children were looked at. Mean age of onset was 7.3 years. Mean time to achieve remission was about 63 days. Mean TAC dose was 0.18 milligram per kg, and the mean duration of follow-up was 290 days, an 84% complete remission, 11% partial remission, and a 5% were non-responders. And this forms the gold standard of therapy today also as far as management of steroid-resistant nephrotic syndrome is concerned. This is some of our work looking at metabolic bone disease in children. We looked at 100 children with nephrotic syndrome, and we found that although we are using steroids left, right, and center, 57% of them had osteopenia, whereas 29% had very severe osteopenia, which in adults we call osteoporosis. Whereas when we looked at the symptoms, only 8 of these children were symptomatic. So this was another problem that we were perhaps creating inadvertently while in an attempt to treat these children. This is a subsequent follow-up study in nephrology dialysis transplantation, prospective work in 100 children with idiopathic nephrotic syndrome and normal renal functions. And what we found was that the factors that were predictive of an improved BMD delta Z score, which is how we look at bone disease and nephrotic syndrome, are younger age at bone density, calcium and vitamin D supplementation, a greater calcium intake, and lower steroid disease dose per year, again highlighting the need for early intervention with non-steroid protocols, and also using calcium and vitamin D supplements, which is again now in the IPNA guidelines as far as management of nephrotic syndrome is concerned. This is my paper in NEJM. This was a paper by Mary Leonard's group from US, which actually reported quite contrary, and in their group they didn't find any relation of steroids with low bone densities. But what we pointed out was, first and foremost, there was no correlation of the doses of steroids with the bone mineral content. They had done bone mineral content and not bone densities. Uh, the Z scores of their spine were definitely lower in patient subgroup as compared to their control group. Again, no information on the dietary calcium or vitamin D intake, and a lot of food supplementation is done in US, which might have resulted in protective effect of the steroids. And genetic factors was certainly an issue as to why we may be seeing more osteopenia, osteoporosis. This is our subsequent work from SCPGI looking at genetic factors, and we did identify certain genotypes which were predictive of low BMD scores, namely the TAC-A1 and APA-I1 genotype of the vitamin D receptor gene, which could be predictive of the low bone mass. Again, nephrotic syndrome, we all know, is genetic disease. For steroid-sensitive nephrotic syndrome, we still do not have any etiology, and this is some of the work with HLA markers, and we were able to identify this unique marker which was perhaps predictive of steroid resistance, and the hypothalamic susceptibility gene of steroid-resistant nephrotic syndrome could be perhaps located at the DR beta 1 150X and DQ beta 1 060X haplotype. So these are two books. This is a childhood renal disorder group, which I was an editor, and I've also contributed a chapter on steroid-resistant nephrotic syndrome and the IAP textbook of pediatrics. Nevertheless, nephrotic syndrome, is a difficult disease to, and this is to quote Louis Barnes, that few diseases tax the resources of the practitioner so extensively as the nephrotic syndrome. He must be a combination of an infectious disease expert, nutritionist, physiologist, psychiatrist, pediatrician and nephrologist for the patient, and above all, guide, counselor and friend to parents. So it remains a difficult disease to treat, whatever we might think. This is some of our work in acute kidney injury. We looked at the pattern in a referral hospital, namely SCPGI, and we were able to identify that HUS was coming up in a big way. This is looking at cardiac tamponade, peritoneal dialysis, and we also used plasma infusion in atypical HUS, and this was obviously in the pre-eculizumab and pre-rituximab era where we were left with very little, but at that point of time this did benefit these patients. This is our experience with crescentic glomerulonephritis, which is like a medical emergency as far as children are concerned. And in our spectrum, the immune complex glomerulonephritis was the commonest cause of crescentic glomerulonephritis, followed by anti-GBM disease and post-immune glomerulonephritis was an important cause. The outcome was not good because there was a delayed diagnosis and referral with a mean duration of symptoms of nearly 2.5 months prior to referral. By that time, fibrosis always sets in. High frequency of chronicity changes was seen on kidney biopsy. We found fibrocellular crescents and glomerular cirrhosis. And what we concluded was that a greater awareness of this entity needs to be created amongst the pediatricians so that we have an early referral. And I believe things have changed. As I spoke to Dr. Badoria, my junior colleague at SCPGI, that they are seeing a change as far as the pattern is concerned. They're getting these patients earlier. This is some of our work on chronic kidney disease in children. This was our first paper on the etiology and outcome of chronic kidney disease in Indian children, and we see that Kakut was the commonest cause, followed by glomerulonephritis and hereditary diseases in a small component. But what we also found was that a lot of this chronic kidney disease is reversible. About 1/4 of these children had reversible factors like volume depletion, NSAIDs, infections and hypertension. And if you pay attention to these issues, there is dramatic improvement in kidney function, and these families remain indebted to you for improvement in kidney function in what is otherwise a progressive disease. What we also concluded was that the prognosis by and large was poor in these children because of late referral, limited availability and high cost of renal replacement therapy. This is our outcome data. As you can see, the moment CKD was diagnosed, 39% straight away opted out. Another 17%, another 21% opted for conservative therapy, 8% died, and this was really opted out. Very small number of subgroup persisted in dialysis, and just 17% opted for renal transplant, which is the definitive therapy as far as chronic kidney disease is concerned in children. And these are the different options. Some of the children that we have managed, you could use CAPD, hemodialysis, kidney transplant. This is our first paper, one of the largest from our country, on continuous peritoneal dialysis in children, a single center experience. We looked at 30 children, mean age of 13 years, mean follow-up of 15 months, a mean break-in period of 12 plus minus 3 days were given. The peritonitis rate was acceptable, and mind you, this was done using continuous ambulatory peritoneal dialysis because of cost constraints, and not APD using the cyclers, which is by and large, is not affordable in our country. And what we found was that it was a useful modality with a mean cumulative survival on CAPD of 45 months. This is a subsequent follow-up study published by Narayan Prasad of some of our patients. There are 66 patients. The number pool had increased. Mean age was 12.3 years. The total duration of CAPD was nearly 108 years. The mean patient survival on CAPD was 41 months, and the mean death-censored technique survival was a very impressive 54.5 months, and 42% of these children were attending school time despite using this intensive CAPD protocol, 9% part-time also. This is one of my papers published in Kidney International looking at the issue of technique failure. Our experience from Sick Kids Toronto, where I had the opportunity to do fellowship. And the two factors predicting technique failure was low serum albumin at 1 month and recurrent peritonitis. By highlighting the need of aggressive nutritional therapy in these patients, especially who are on long-term continuous peritoneal dialysis. Some of our work in kidney transplant, way back in 1995, we had an editorial highlighting that kidney transplant is the optimal mode for renal replacement therapy, and we should be moving towards preemptive kidney transplant. Our subsequent experience published in Indian Pediatrics 2001. We have also looked at factors influencing growth and final height after transplantation and the outcome of pediatric transplants in a developing country. This is one such child. We did a preemptive transplantation, and what we highlighted was that it has advantages in terms of economic, that you save on the cost of dialysis, it minimizes malnutrition, uremic complications, infections, and these patients have a far better outcome as compared to those who were subjected to dialysis and then went ahead with the kidney transplant. This is our initial experience of pediatric transplants from SCPGI, 39 patients, one of the largest at that point of time. 1 year survival 89%, 3 years 70%, 5 year going down to 50%, majority because of poor compliance, because at that time innovator cyclosporin was the only brand that was being used. Subsequent studies, follow-up study, this is our experience published in Journal Nephrology and Renal Transplantation with 50 patients using the TAC MMF prednisone. As you can see, 1 year survival here, 98%, graft survival, 5 years, 85%. Again, a lot of industry contribution because the generics had become available, and highlights how the Indian generic industry has contributed significantly to improved outcomes as far as kidney transplantation are concerned. What are the factors looking at influencing growth and final height after renal transplantation? Some of the experience during my fellowship at Royal Children's Hospital, Melbourne, Australia. Etiology, age at transplant, pre-transplant growth, renal function post-transplant, steroids, renal osteodystrophy, and post-transplant sexual maturation. And what we also found was that alternate day prednisone is a very cheap and effective way to improve height after transplantation, especially in our country where growth hormone remains beyond the reach of the vast majority of the patient population. This is some of our work during COVID, and as you know, COVID struck us like a bolt from the blue, and I think children were the most vulnerable of the lot, because even after vaccine was introduced, children were denied vaccination, and the only way to continue to take care of these children was through telemedicine. This was published in Pediatric Nephrology, and what we concluded was that a low-cost telenephrology model, using simple WhatsApp, along with an email and an electronic medical record, offered an effective method for providing continued pediatric nephrology access during the period of pandemic lockdown when access to pediatric nephrology care was limited. This is a follow-up study where we continued using this low-cost model, and pediatric nephrologists are not easily available in each and every city. A lot of these families have to travel large distances, and what we found was that telemedicine is a useful modality in following up these children, and it helps also in triaging these patients who need to come to a higher center for follow-up. Therefore, it is cost effective and time saving for the family and helps in improved compliance with therapy, which often results in loss of earning for the family members when they come for follow-up. And last but not the least, this is the role of the nephrologist in bridging the knowledge gap, which was last World Kidney Day's motto. But this theme is very relevant today because a lot of our patients, are misguided by social media, who they consider as the final frontier. We have a lot of patients going to Facebook, Instagram, Twitter, and YouTube for trying to find out the best therapies, and it's not surprising that they are misled, and they often end up spending lakhs of rupees, which could have perhaps been very optimally utilized in improving the results of therapy. So during this pandemic, I launched my own YouTube channel, and this is currently, I think I have more than 30,000 subscribers, more than 20 lakh views. And we also now, after I've taken over as the president of the ISN, the Indian Society of Nephrology also has launched its own YouTube channel to give these patients an authoritative view, an alternative view, and also bring them up to date with what the recent advances in therapeutics in the field of kidney diseases. So I would like to acknowledge several people. First and foremost, Professor P.D. Gulati, who inspired me into nephrology. Professor B.N.S. Walia, who was the head of pediatrics at PGI Chandigarh and always, egged us to do much more than pediatrics. Professor Vijay Kher, Professor R.K. Sharma, Professor Amit Gupta, who were my teachers at SGPGI, and Professor Narayan Prasad, who's been a key collaborator for much of my work, and he's carried on some of the work that we initiated. Professor Harley Powell at Royal Children's Melbourne, Chris Reed at Guy's Hospital, UK, Alan Watzel at Nottingham, Bill Balfe at Sick Kids, Dennis Gary at Sick Kids, and Brian Steele at McMaster Children, where and not to forget my wife and two daughters who have been here, and also the patients, who reposed the faith in me and persisted with our therapy, some of which may not have been very good. So, and on this note from Robert Frost, that a lot has been done, but a lot more needs to be done, and we have promises to keep and miles to go before we sleep. Thank you.
Thank you, Professor Dr. Gulati, sir. Professor Dr. I.V. Sinha was my mentor, and I worked under him as house physician. And I was with him throughout his life at PMCH. I also give my thanks to the organizing committee that they have started Oration program. I also thanks to ma'am that she has come here to give us blessings. We are always in need, ma'am, and we are expecting you will give us blessings. Thank you.
May we request Madam Sinha to hand over the medallion to today's speaker, Professor Gulati.
Kumudni Sinha ma'am, please come on the stage. And may I also request Dr. Professor Hemant Kumar sir to present the medal to the speaker, Dr. Sanjeev Gulati sir and madam. medal in name of Dr. Professor I.B. Sinha being presented to Sanjeev Gulati sir.
Give a homage to our reverend teacher, Professor I.B. Sinha. And this is a really a moment where we must pay regard to our Madam, Dr. Professor Kumudni Sinha, who has taken all the emotions here to share the moments which we spent a long back for a long journey with Professor I.B. Sinha. Thank you very much, Madam, for coming to this forum and giving your blessings to all of us in this assembly. Thank you very much. And I will request Madam to speak a few words.
Good afternoon to all of you. Sorry, good morning to all of you. Please be seated. Thank you. As Dr. Hemant has asked me to say few words, I'm thankful to him. Rather, that is here, I am here because of Dr. Sinha only. And so, all of them who are here, they have given me lot of love for him, and that is the nephrology here is the extended family of mine. Now, I don't have the idea of any protocol, but I start with organizing chairman Dr. Hemant, organizing secretary Dr. Om, dignitaries on the dais, off the dais, distinguished guests, faculties, ladies and gentlemen. When Hemant came to me on Wednesday to tell me that you have to come to give this medal, I was taken aback. Really, I am saying that I was taken aback. There are a lot of important personalities for giving this medal. But for me, it come a dream come true. It is honor for me. Rather, I am feeling privileged and grateful for giving me this honor to give, as I have given it already, to, and that is the I.B. Sinha Oration 2023 medal for his excellent and legendary talk on kidney disease and children. Now, it was a memorable moment for me, and it will remain in my mind for my lifetime till I am alive, that I have given this medal to a legend in the memory of the another legend and the father figure of nephrology, Dr. Sinha. I can say him, though I shouldn't say that, he was a complete personality and a perfect package of everything. Teacher, father, husband, friend, and everything. Now I see the seed that was planted, I think about 4 decades before, with few members, it has turned into a big tree now. Because there are so many nephrologists here in Bihar itself, and that seed was planted, I don't exactly remember the day, but that seed was planted almost 4 decades ago with 4 or 5 nephrologists of Bihar. Now, there are more than, I think about 35 or more than 35. So, he must be looking from there, from heaven, and he must be thinking that this big tree should give shadow in form of care and concern, and treatment in form of fruits to the ailing society and ailing humanity. I'm thankful again to Dr. Om, Dr. Hemant, ISN members, ISN East Zone, all the committee members of this CME 2023, and all the persons and the nephrologists for giving me this honor and making my day memorable for my life long. Thank you very much. Stay blessed. Thank you so much.
Thank you, madam. Thank you for your blessings to this entire session. Through you, we have seen Dr. Professor I.B. Sinha today. Next, we will move on to the next session. This is a panel discussion session. And for this session, I like to call upon the chairperson. Uh, Chairperson Dr. D.S. Ray sir. Sir is a senior consultant and the chief of renal transplant, Department of Nephrology at R.N. Tagore Institute, Kolkata. I'd request D.S. Ray sir, who is already busy, but after he finishes off the photo session, then please come to the chair and kindly introduce the panelists and the moderator for the session. There is a slight change as sir has already announced. So the chairperson I'd like to call Dr. Professor Ehsan Ahmed. Sir is a professor in Department of Urology, IGIMS Patna. Dr. Ehsan Ahmed sir, kindly come to the chair and introduce the moderator as well as the panelists for the session.
Today, the session on the pediatric transplant challenges. The moderator is Senior Consultant Pediatric Nephrologist, Dr. Rajiv Sinha, Institute of Child Health, Kolkata. I welcome on the stage dash. Dr. Ranjan Sinha, sir, please come.
Yeah.
The panelists for this discussion, they are Dr. Arpita Rai Chaudhary, Dr. Pradeep Chakravarti, Dr. Shubhal Pardhan, and Dr. Anshuman Saha. They are also requested to come on the stage.
So, shall we start?
Yeah, we shall start. Please, sir.
Thank you, sir. Sorry for my voice. I'm recovering from a cough and cold. Maybe I don't know. But not COVID. So we will be talking about the pediatric kidney transplantation. And at the onset, I would like to thank the organizing team and particularly Professor Hemant Kumar for bringing this amalgam of pediatric and adult nephrologists and pediatricians. Obviously, I will not be covering all the challenges and solutions, and we will be focusing on few of them. And we all know what are the challenges, starting from knowledge barrier to lack of access of appropriate healthcare, social barriers, economic barriers, and medical surgical barriers, and policy barriers. Again, we won't be covering all of them, but hopefully we will be touching on most of them. So we start with our first case scenario of this 5-year-old girl. So she presented initially when she was 9 months old. So this is her initial picture with a CKD from bilateral dysplastic kidney. Went on to CAPD at 3 years. And when she came to us, she was on CAPD for the last 3-4 years. So my question is that should we be thinking of a kidney transplantation in this child? This child seems to be doing well on CAPD, attending school. So, and this question is for Subal, Dr. Subal Pradhan.
Good morning to all. At the outset, I would like to thank the organizers for the invitations and wonderful hospitality. So as you all know that transplantation is the treatment modality or preferred treatment for all cases of end-stage renal disease. It has significant survival advantages. Besides, also it confer improvement in quality of health as well as growth and development. In the previous session, so Dr. Gulati has highlighted that all these transplantations helps him to achieve the catch-up growth later on, before less than 6 years of age.
So as this slide shows, what Dr. Subal said, that the transplantation is the only way in which you can achieve 50% of the kidney function. I don't need to preach to the nephrologist, but there are pediatricians around who would like to appreciate this. And if we don't catch the worm early, then we will miss the worm, because if you don't do the transplantation early, then you don't have the catch-up growth. And often in India, and this is something we'd like to emphasize, that we say that बड़ा होने से किया जाएगा, 10 साल, 12 साल, 14 साल उसके बाद transplant करेंगे. But then adolescents have the worst prognosis in pediatric age group. We all know that for kidney transplantation, and we also mentioned on the catch-up growth. So we all agree, I think all the panelists agrees that we should go for the kidney transplantation in this child. So this question is for Angsuman, like what is the most important requirement for kidney transplantation?
So basically when we are planning for kidney transplantation in children, so 3 things we have to evaluate, like evaluation for the...
But what is the number one thing you require for the kidney transplant?
There should be a donor available.
So we should have a kidney, right?
Yes.
Everyone agrees. And this was a picture drawn by a child, not in India, from Gauss, who was on dialysis. And what she said, that if someone is willing to donate a kidney to you and it matches, nowadays we can even do without matches, you can have a kidney transplant. So you require a kidney. And next we will come to Dr. Pradeep Chakravarti, that who can be a donor?
The best donor or preferable donor will be somebody who is, we call a living related or a living kidney donor, either related or unrelated, HLA compatible and ABO compatible. Next will be a deceased kidney donor. The results are a little less because of more attrition to those kidneys when they are procured. And I would not recommend pediatric donors for pediatric transplantees.
So very succinctly said, this is a list of pre-transplant workup, which I will not go through it. And as Dr. Chakravarti said, that living better than deceased, but no kidney is the worst thing. Donor age 18 to 49 is supposed to be very good for pediatric, and if you are having a matched kidney, it is better. So now we have decided that mother has said that she is ready to donate, and mother was worked up, was normal. So Angsuman, what else information do you want?
We need to assess the risk of rejection, the risk of infection, and more importantly, particularly in children, evaluation of the lower unit tract, whether it is ready for transplantation or not. So in the evaluation of immunological risk, what we do is a basic HLA of both the donor and the recipient, and look for presence of any donor-specific antibodies by doing a lymphocyte cross-match, and preferably flow cross-match or at least one single bead antigen assay. For evaluation of infection risk, most important thing is the immunization, the patient should be immunized completely. The anti-HBs status should be more than 10. Varicella immunization also is very important. And we evaluate for the CMV positivity also. And regarding the evaluation of lower unit tract, because most of the ESKD are acute. So even if there is no hydronephrosis, the patient should be completely evaluated for lower urinary tract, like right from the history of recurrent infections, the voiding diary, a MCUZ, and if required, UDS.
So what is important, I think a bit difference from the adult will be the evaluation of the bladder. So because many of these children who going to ESRD are from bladder dysfunctions. They might be having reflux, dysplastic or valve neurogenic bladder. So that is the most important message. In this child, everything was okay. We went ahead, we were thinking of going for transplant, but this child is just about 12 kilos. So my question is to all the medical nephrologists, does size matter?
No, we are very comfortable in the adult segment with urologists doing well with more than 15 kg. I think in pediatric transplant surgeons who are used to do with pediatrics, they are now doing even below 10 kg. So 10
but
to
then,
15
but then does
or
size matter?
Size of the child. No, weight of the child does matter, but not the size. And the kidney size is, adult kidney size is quite acceptable, as already Dr. Chakraborty mentioned.
So in pediatric KT, definitely size does matter because it does, like we can do it, but it does have, comes with the challenges. And Dr. Chakraborty, if you can elaborate on the challenges and some tips.
This is a very important question and quite very much asked from the surgical standpoint. Size matters, depends on the experience and the expertise of the care provider. I personally categorize children for receiving a kidney into 3 weight categories. The smallest, 10 to 15, or let's say 10. Then the next category is 10 to 30 kilograms, and the third will be above 30. So and then it depends. If they are in the first group, you need to place the kidney at a higher position, lower aorta, and you can go for the common iliacs if they are in the other 2 groups. Mind you, one thing is very important from the surgical technique in doing this is the area of anastomosis, or let's say the circumference of anastomosis is very important, because if in a very young recipient, if this anastomosis is has a small surface area, when the child grows, it causes renal artery stenosis, and which leads to uncontrolled hypertension and renal dysfunction. So that is important. And also a second, which is a part of physics that we learned in school, is if the renal artery or the allograft artery should be, the diameter of that artery should not be more than the diameter of the feeding artery. So that is an important point. And if you keep these 2 in mind, I think it really helps. So
bottom line is that size does matter, but then it can be overcome if you have got the anesthetic expertise, the surgical expertise, and the post-surgical management in the medical expertise. We did this survey way back in 2017, and there were very few centers across India, and only 1 or 2 centers in eastern India who were doing pediatric KT in large numbers, and hardly any within less than 15 to 20 kilos. And this slide mainly to show that yes, within less than 10 kilos also you can do transplant if you have got expertise, but then this should be restricted to very selective number of children. Ideally is that you should make them grow well by good nutrition and good dialysis, and then once they are 10 and above, then transplant. So this child was transplanted successfully, and this is very recently. So this is a child who was diagnosed at 9 months with CKD, went on to have a CAPD from 3 years, now is about 13 years, and dancing. So things can be achieved. We move on to a 8-year-old boy who was operated at meningomyelocele and then presented to us with ESRD and was ready for the transplant. But are we ready, Urpitadi?
We need a safe bladder. This child, by presence of meningomyelocele, gives a clinical pointer that he might be having a neurologic bladder. So, compatibility of CIC, doing CIC with the family and the child during counseling, and a workup with video urodynamic study, so that we can look at the capacity and the pressure of the bladder and advise for an augmented bladder creation.
So, firstly, I would say it was criminal that this child went into end-stage renal failure after being operated at within 1 month. Why? No, because according to the family, nobody had counseled them for CIC. They were under follow-up, but nobody mentioned about CIC. So it is a criminal, and it shows we are sending men to the moon and blasting nuclear bombs, but we still have a lot to do. Sorry, it's my personal opinion. So this child actually had a neurogenic bladder, as you can see, and as Orpita said, that needs a safe bladder. So in this particular child, because this bladder was so small, we went for an augmentation and mitrophenol. This is the mitrophenol, how it is done, like you can put in the catheter through your tummy. And the child was transplanted successfully. So Luto, we heard yesterday also, lower urinary tract obstruction does give us a lot of challenges, but again these challenges can be overcome. This particular child also had a PUV, but then had a stable bladder. So we went on with the transplantation, and this child is now almost 10 years gone and is doing quite well with a creatinine of 0.7. This one was the child that I just showed. This one is a very peculiar case. This child came with, had a PUV, went on to have ESRD, and when this child came to us, this was the anatomy. So you see what they had done in Vellore was to save the kidney, was that they had anastomosed both the ureter and it was coming out in a conduit, like a ureterostomy. So we said that your bladder has to be made safe. You will need one surgery for making the bladder safe, and then we will implant your kidney into that new bladder. But this child said, I don't want any other surgery. I have undergone, by that time had undergone 4 surgeries. The only surgery I agree is a transplant, otherwise I will not do. So after a lot of counseling, this was done. This is what the child agreed, that okay, you will do just the transplant surgery, and the new transplant ureter was anastomosed into that old stoma that was coming out. Now this child is 21 years old, has moved over to UK for further studies, and he is still happy with this. I have told him that how are you finding a girlfriend, but he apparently has found one girlfriend also. So I don't know. It all shows that we don't appreciate the patient perspective, because I had a real fight with the child and the family at the start, but he seems to be doing very well. Moving on to our third one is the child with ESRD with FSGS. So again, Arpita, how would you counsel the family?
Whenever you see an FSGS, you need to classify them whether they are primary FSGS or secondary FSGS or a genetic FSGS. This goes the first thing. If you think that it is a idiopathic primary FSGS, then you have to counsel the family that at least 1/3 may come back, and there is an increased risk of losing the graft if it does come back. Definitely those who come back, in whom the recurrence is there, it's not that everybody proceeds to graft failure. Around 47 to 50% did have an improvement and can continue after plasmapheresis and nowadays with retux. But definitely a lot of counseling is required, and we should ask them to go for a genetic testing so that if the genetic testing comes positive, as the data shows, that genetic FSGS recurs least rather, so we have a comfortable zone of counseling that yes, you are least likely to get the disease back.
So from my own practice, what we have found is that when I counsel the parents that there is a chance of recurrence, then the usual thing is that kidney bhi jayega, paisa bhi jayega. We will lose both the kidney as well as the money. And in India, it does matter. Deceased donor transplant is often not available, and that also involves money. So we did this study from our own center, and INCENT was also involved in this as a guide. And what we found was that if we are counseling them with a genetic report, then the chances of saying yes to transplantation increases significantly. If you are counseling without, so with a genetic report, you are saying that go ahead with the kidney transplantation, there is less chance of recurrence. So we went ahead with the genetic counseling, genetic test, and this child, this is the index child, came up with a compound heterozygous for the COL4 mutation. Unfortunately, both parents were carrier, and as you know that you shouldn't go ahead with this in COL4, and they underwent a transplantation by unrelated. We move on to our fourth case scenario of bilateral dysplastic kidney. The child is CKD stage 4. GFR calculation was 16, was quite tall and healthy, but is complaining of difficulties in keeping up with the peers. So, Dr. Subal, do you really need this child? Needs a kidney replacement therapy?
So, eGFR is not the sole criteria for taking decisions for considering transplantation, particularly in children, because there are so many other factors, particularly in children like growth and development. If the child having a persistent growth failure or developmental delay or persistent metabolic acidosis or on multiple drugs for hypertension, such children should be considered for transplantation.
So again, quite different from the adult here is that these three aspects, we really consider it more seriously. And we all have agreed already that transplantation is the best way forward, but then this child is not on dialysis. So should we start dialysis and then transplant, or should we go for a preemptive transplant? So Arpitadi, your comment on preemptive transplant.
Yes, of course. Preemptive transplant, particularly we consider at the CKD stage 4, it is very important to pick up preemptive transplant in children because the growth issue is strongly there, and we know that the transplant answers best in terms of growth, in terms of other quality of life issues. So what I would like to say here, that there is a 2014 amendment of the HOTA Act, and grandparents may be included as the first living donor to the child for preemptive, as still not there is a allowance for enlisting them for deceased donor if they are without dialysis. And one more thing, we may work up with NOTO to include the children in preemptive state only for dialysis. And one more thing, that deceased donor enlisting should be done more and more for these children because they have many extra points. So they can come up, if the organ is available, they can surpass the adult patients enlisted above, and then they can come up and get before the average waiting period. As Eastern Zone is already in Kolkata,
we will be coming to that.
Odisha.
Yeah. So preemptive kidney transplantation does have advantages, and this was the last one is a study from us only from Great Ormond Street Hospital, where we showed that if you have transplanted them preemptively, then you have a better CKD parameters. But the father, being the single bread earner, is afraid to donate. So Dr. Pradeep Chakravarti, how do you counsel him? Yeah, because he said that I am the bread earner, so how will I donate?
Father or mother, they're optimum donors for their children, being one haplotype match. Counseling them should be very straightforward, should be very honest, and you have to tell them that they're going to undergo a major procedure. We do our transplant donor nephrectomies laparoscopically, and they get admitted the day before, day of operation, they get the laparoscopic donor nephrectomy, and nearly 80% of our donors are discharged the next day or the day thereafter. So this really matters, that how many days I'm going to stay in the hospital, and then what can I do after, am I going to be as I am now? So we need to tell them to get in touch with some of the donors that we have
Yeah,
done.
that's often a
and
good
counsel.
idea.
And the most important thing is that to reassure them that statistically it is shown that when they have people who have donated 10,000 donors, round about 30 end up with chronic kidney disease after a period of 15 years. And in comparison to the general population, we're around about more than 326 approximately, when they're followed up, in general population end up with chronic kidney disease. So their chances is 1/10 compared to the...
Maybe because of the more closer follow-up.
So, these reassures them, and I think these are the basic things that they need to know and go ahead with.
So this is the father.
Hello, I am Ujjal Roy, father of Upam Roy. As told by Upam, I am the living kidney donor for my son Upam. Donation of kidney is very easy, and
So
it
this
takes only
father
5
is an
days
engineer,
to
and
stay
he was back to work within a month.
in hospital.
And this is the child.
Hello everybody, myself Upam Roy. So a few months ago, or better to tell 7 months ago, I underwent live kidney transplantation. Why? I was suffering from CKD or chronic kidney disease stage 5. My creatinine level suited to 5.9, which was very critical. So as told by my doctor, undergoing transplantation before the starting of dialysis gives a very better output. So living donation was must for me, so my father decided to donate. Before transplantation, I cannot concentrate in study, or
So
I got exhausted.
he goes on to say that before he was this, now he is much better. And I usually show this to the family, and sometimes it makes difference. So this child was transplanted. We are going on to our next case scenario. A child with a WT1 mutation had a nephrectomy at 1.5 years because of Wilms tumor, but then also had a nephrotic syndrome, and then went on dialysis, and now is hypertensive. But the family is very eager for transplantation. So are we ready for the transplant?
As we discussed before, this is a genetic FSGS, so that's
So
a very
then
good
he will
prognosis.
not relapse.
He will not, so that's a good thing. So we
So
can
are we
proceed.
ready?
We can proceed, but the nephrectomy has been done for, I think, for hypertension.
One side has been done, the other kidney is still there.
But still refractory hypertension is there. So in that situation, we can consider that native kidney nephrectomy. But native kidney nephrectomy is usually not done and not required in pediatric kidney transplant. There are some indications that have been listed here.
So this is like we hardly do a pre-transplant nephrectomy, but in this particular child with 4 antihypertensive and also with a WT1 mutation, we went ahead with the nephrectomy, and then the child went on to have a transplant done. Questionnaire 6, as a 6-year-old boy, end-stage renal failure secondary to ARPKD, was on dialysis. The current weight is 13.6 kilo. We have already known that weight is a challenge but can be overcome. But the blood group of child was O positive, mother is B positive, and father is O positive and is hypertensive on 2 drugs and is having significant proteinuria. So what are the options for his kidney transplant? We thought of a deceased donor, and at that time, unfortunately, I mean, deceased donor is an option, but then at that time, unfortunately, Kolkata did not have a deceased donor program. So, Arpita ji, what is the current status of this disease donor program in Kolkata and in Eastern India also?
Yeah, in Kolkata, Orissa, and to some extent Bihar also have started doing deceased donor kidney transplantation. Kolkata is little ahead. Yeah, last year we had done 25 deceased donor transplant, and we have done. If we look at the outcome of the transplant, there is 98% patient survival, and death censored graft survival is 100%. So you can see that 1 year outcome is quite good. So we can move for a deceased donor transplant. And what I find that enlisting is also laced. We have to push and push for other nephrologists that get them enlisted in the deceased donor program. And what I was telling you, they can even cross the average year period. The average waiting period may be little shorter for them. As you can see, there are 13 children enlisted in the deceased donor program in SSKM Roto, mostly from SSKM nephrology department only. I would request you all to enlist them.
And do they get any advantage?
Yes.
Age advantage?
They get extra points depending on their age.
But then we still can't do preemptive listing.
No, we are not yet able to agree, make all people agree that they will be.
So that is something seriously should be worked upon.
Seriously should be worked upon.
Angshuman has something to say.
So the NOTO guideline says you have to have on dialysis for at least 3 months to be registered on the wait list. Yeah. So that's what we are from pediatric nephrology community.
Dr. Gulati is saying yes, but as a pediatric nephrologist and a nephrologist, I think you are the person who should be changing the rule or try.
It's not me, but I think it's time to work with the government, and the ISM has created a liaison committee. Georgie Abraham is not here. He is also the president of the Indian Society of Transplant, and Professor Hemant again is a part of the liaison committee. And these people, I think, Professor Srivastav is sitting here, and we have been discussing a couple of points. He's been guiding us. So I think it's time for everyone to work together. The ISPN and the Indian Society of Nephrology need to work together on several points. Earlier during the day, we had the issue of eculizumab. Now is this issue of preemptive listing. No child can be listed preemptively. Arpita is absolutely right. We have been struggling. Writing to NOTO doesn't work.
Maybe you can leave this legacy for us.
No, I think work together with the president of the ISN, and the ISN as well as the ISPN could work together, jointly formulate a letter. And right, the government is so much on its plate, they don't worry, they are not concerned about transplant. But we have to lobby with them. This is the era of lobbying, let's be honest about it.
Yeah. So we will
have a NOTO session with the ISOT people. I think that there we have the best thing, that half a day NOTO session is there.
Hopefully things will improve, and I'm not expecting that we'll come to a decision at this forum now, but hopefully we have highlighted this, and what is very good that we have got the ISN president, the ISOT president, so all of them can be around, and we also had the ISPN secretary Aditi also around, so maybe in future we can move forward more seamlessly. But going back to Angshuman, we didn't have a deceased donor transplant, so what is the other option?
So you have two options, like you can go for a ABO incompatible, or you can go for a kidney paired exchange. But since the blood group of the child is O positive, the paired kidney exchange will not be possible, because the donor is, we can give to kidney to his or her own relative itself. So the ABO incompatible is a definite possibility. And with the advent of plasmapheresis and antibody-specific immunoadjuvant, the outcome is quite good now, almost comparable with the.
But the meta-analysis is the same.
Yeah, the Lancet analysis showed that there is increased mortality in the first 3 years.
I follow meta-analysis. After reading that, I am completely against ABO.
No, but you have to see that the comparison with the wrong population. What is the alternative the child has? The child stays on the waiting list. And the wait list on dialysis, mortality is 30 times higher than normal population.
So what Angshuman is saying again is half a loaf is better than no loaf. So any kidney is better than no kidney. Please, this is true for adult, this is true for pediatric also, please. So that was one of the indications. Paired donor we have already covered. But in this particular child, they went for the unrelated transplantation, and the transplantation happened nicely. So, about 9 years, started developing recurrent cholangitis. You remember the child at ARPKD? So, recurrent cholangitis. Now they went for liver transplantation, and this is the child now at 12 years with liver and kidney transplanted successfully, doing quite well. Creatine 0.73, liver enzymes okay, and I'm sure all of you will agree that he is a superman. So going from a superman, I would lastly like to go to a story of a super girl. This child came to us around 9 years old, was initially managed at ICH for a month or so, was not improving. People from West Bengal and eastern region don't really have much faith on us, it seems, and they went over to another center. And there the child had a biopsy, was chronic GN, nothing happened, and was on hemodialysis. This is how the child again came back to us, because they had to come back to their home sometimes. So was pale, anasarca, cold extremities, poor sensorium, stage 2 hypertension. But whenever you put this child on, so the echo and everything was showing that the child was overloaded. But whenever you put this child on dialysis, the BP used to drop to 60s within first hour on HD. It was a real nightmare. Whenever this child has severe orthopnea, this was the echo. You can, at that time, you can see hardly contracting. In fact, the cardiologist started the child on anti-clotting because was quite worried that because of this poor contraction, there will be the thrombus in the system. Ejection fraction was 15%. So, was having a cardiorenal syndrome like type 4. So this question is for all of you, like would you accept this child for a transplant?
I think the EF is quite poor. We know that following transplantations with normalization of kidney functions, that improves some cardiometabolic parameters like anemia, fluid overload. But particularly in this child with EF of 50%, he may not tolerate the surgery. So again, it is win-win situations. So you have to decide with the team, maybe team approach.
So then how do I do the dialysis? PD was not working. Dialysis, within an hour this child blood pressure went down and started having all those symptoms were aggravated. It was complete nightmare, and the family was counseled that you go for a heart transplant, and after heart transplant we can do the kidney transplant. Father came and told me that kidney nahi ho raha hai, to hum log heart kahan se laye? So it was a real nightmare. What we did was that we initiated this child on daily hemodialysis, initially SLADE, and then at least 4 to 5 hours daily. And as you can see here, that slowly with the dialysis, the weight came down slowly. It took time, almost more than a year, and the ejection fraction went on slowly increasing. And now this ejection fraction after almost 1.5 years was about 50%. So this something is like many of us might have seen them anecdotally, but then it's not really published that much, that in children with a 15% ejection fraction, and that was not a one-off occasion, it was like that for at least 5-6 months, but that it can improve with proper dialysis and intensive dialysis, not only proper intensive dialysis. So now the transplant surgeon and the team was happy that yes, 30-40% ho gaya, we will do the transplant. So I said that we are ready for the transplant. Good, we will have this. The family is struggling a lot, so we will have the transplant. But now we made the big V of poverty. The family said that हम लोग का जो भी पैसा था तो यही dialysis में चला गया. We don't have a single penny. So I would like to have your opinion that what do you do in this sort of a case? So we can start with Angsuman, who works in a Modi's state. So आपको तो पैसा का problem नहीं होता होगा ना?
There is a very good program going on in Gujarat with collaboration of Government of India and state government. So it's called a school health program, and it's completely state funded, like the ESRD care and the transplantation, immunosuppression, post-transplant immunosuppression up to age of 18 years. It's completely state funded if you are a native of Gujarat. And of late, the PMJY also is included. So if you have a PMJY card, that is covered. The initial pre-transplant
So
workup,
then money is not a problem
money
for
is
you.
not an issue.
Subal?
Yeah, same thing for us. We have a state scheme that provide up to 5 lakhs one time, and then also some mentalist
तो
medications.
5 लाख में हो जाता है.
Yes.
And expertise, do you have the surgical expertise?
Still again, our surgical team is not comfortable, less than 15 kg. They have done bit older children.
So,
maybe
so that
struggling,
part is
yeah,
developing.
Yes, yes.
Arpita ji,
So-
from Didi's state?
Yes, we have two advantages, the Shastra Shati and the PM NDT program.
Huh?
Both the PM NDT, first thing is to overcome the barrier of dialysis.
मोदी कलकत्ता में पैसा देता है.
हाँ हाँ हाँ, we have in all districts we have, actually Didi doesn't always agree with that it's done by Modi. Didi accepts that it's done by her also. Whoever, we are the beneficiary part. I am not in struggle between Didi and Modi, or Modi alone or Didi alone. But what we enjoy is now that almost in most districts we have dialysis program, and that dialysis can be done without any cost. So
Transplant.
one issue, transplant, yes. Transplant is done without any cost in the transplant hospitals.
And your surgical expertise, are they happy?
Surgical expertise is again same with Shubal. In government setup, we don't have compatible with the lower than 10 kg or very risky, just 2 to 5 year old, where you find the anastomotic problems most. So those cases are not done in our setup. But what you told, first thing is the dialysis barrier, because we also find this type of renocardiac cases where we find significant volume overload, difficulty in continuing dialysis in the peripheral centers. Then the answer is from the peripheral centers. One other blessing is COVID. We have developed very close interaction with the peripheral centers. They can inform us, we can get him in our dialysis. And every day we can do intensive dialysis, SLADE, everything we can afford in IPGMER, we are doing that and maturing the patient to transplant possible stage.
But you don't have a pediatric nephrologist.
Yeah, don't have a pediatric nephrologist. We
Sorry.
will be happy if we can include you or Shumantro in our panel.
Sorry. Pradipta, so you are working in a center which is well equipped to do even small children, and you have got the expertise. But then what about the money? How do you overcome that?
I have spoken to, and I get spoken to quite a few NGOs, and quite a few of them, I was surprised, they come and do help us. There are at least 3 of them who are very generous in helping our poor population, especially pediatric population, also adults. And our hospital is also, on a case-to-case basis, do help, a certain sect of people, provided they qualify for that.
So the bottom line is, and this is a very important take-home message that and that's what I tell the family also, that money is not a barrier. When they come, they say that paisa nahi hai to hum log kaise kare, but money is not the barrier. Barrier is, we will be discussing now, is later on, that it is the mentality. Money barrier can be overcome. CMRI in fact is doing kidney transplantation if you are poor, completely free. And we have got Arpita Di, we have got Subal Center and Anshuman Center, who are also doing it almost free or completely free. Expertise are developing, but money is not an issue. So fairy tales can come true. Really believe me that this child made me very happy. That when this child got transplanted from a no hope situation, and finger crossed, at present is doing quite well. So KT is the preferred mode of KRT in children with ESKD, with excellent short and long term outcome. Despite its feasibility in most of the children, the rate of KT acceptance is still very low because of multiple challenges. Lack of locally available facilities of pediatric KT, lack of kidney, lack of finance, but I really believe that it's lack of awareness. Lack of awareness among the family, which is, I believe, is very important, but maybe I am sure everyone will agree the lack of awareness in the medical fraternity also, that हाँ इतना छोटा बच्चा में भी kidney transplant किया जा सकता है, but then challenges can be overcome. This is the some of the pictures that was drawn by our children from ICH who had undergone kidney transplantation, and ICH doesn't do the transplantation at the moment. We haven't developed that, but these are all our children. They didn't have any money, and with the help of NGOs we were able to do the kidney transplantation. Thank you very much. And lastly, again a sincere request for all of you to register for the ISPN Con, which is going to be happening in Kolkata in October, and there is this special discount which will be there for today also. Thank you.
Dr. Sinha, please may I just add one thing. It's not a one-man or two-man show doing pediatric kidney transplants or transplant to that effect. We need a team, as we all realize over here, who have been involved. A wonderful talk by Dr. Gulati, very impressive. Pediatric intensivist, pediatric anesthesiologist, pediatric nursing care. We have been able in our institution in Kolkata to set that up one by one. So this teamwork is very important, and I'm sure all the successful programs who have been doing pediatric, especially pediatric transplants or organ transplants realize that. So that is the beginning, that we need to have a trained, dedicated team doing that.
Okay, so thank you. If the chairperson has any comment.
Thank you, sir. Today we have discussed a very challenging topic, pediatric renal transplant. As we have seen through multiple case discussion, which were very informative. The need of pediatric transplant and the outcome is good, and we should not be afraid to saying any these types of pediatric patient needing a transplant. No, we should definitely say yes. There are definitely challenges, but we can overcome. Thank you, moderator Rajiv Sinha sir, and all the panelists for coming here and having a nice discussion.
Thank you very
Thank
much.
you.
Thank you, Dr. Raji, for a very engaging session, going slightly political also, but Bihar is famous for this, so we will take that in the stride. So with this, we will move to the next session. The session is a pediatric CKD, a harbinger of adult onset comorbidities. And for this session, I would like to call upon the chairpersons, Dr. Pratik Das sir. Sir is a senior consultant, nephrologist and kidney transplant physician at R.N. Tagore Institute, Kolkata. Dr. S.A. Krishna, consultant pediatrician from Patna. Dr. Pankaj Misra, consultant nephrologist from Ranchi. And Dr. Manoj Gupta, a consultant nephrologist from Purnia. I'll request the chairpersons to introduce the speaker, Dr. Yinsen C. The session will be of 20 minutes and the discussions are for 5 minutes. Chairpersons, take over the stage.
And after a nice discussion on pediatric transplant, now we move on to this Professor Insen C, who is a consultant pediatric nephrologist and a clinical director for quality and safety in Great North Children's Hospital, Newcastle, UK. And total experience, he is consultant since 2019. His area of interest is pediatric nephrology and medication safety. And he has lots of these achievements and honors and awards and publication in his care. Without wasting time, I would request him to start the talk and enlighten us.
Great, thank you very much. I think I and someone else is here between you and lunch, so I'll make this quick. It's been a delight to have this link with adult nephrology here, and hopefully I'll try to put it all together. Aristotle once said, give me a child until he or she is 7 and I'll show you the person. And I think hopefully by the end of my talk, I can put it all together and illustrate that. I always like to start a talk by linking it with a patient. Imagine a 15-year-old girl with a solitary functioning cystic dysplastic kidney, and the kidney function is not too bad. Its GFR is 50, it's 80, she doesn't feel anything wrong. But the question is, what does her future look like, and what can we do as nephrologists, pediatric nephrologists, adult nephrologists to optimize her life? CACUT, congenital malformation of the kidney and urinary tract, as you all know, is a catch-all term for a number of kidney conditions which are made before a child is born. If you take a bunch of children with CKD, that makes up 50%. It's quite common, 0.5% of live births. It tends to run in families, but not particularly strong. And increasingly, we're finding genes that are responsible or partly responsible for developing CACUT. If you go to adult services, it actually makes quite a small proportion of the work, so maybe it's not such a big focus. And as we were all heard, close working with urologists is really, really important because, you can have patients that are just looked after by kidney consultants and they may forget about the urology side, and similarly, you might have patients only looked after by urologists and they may not see the kidney side. In kidney development, it starts off very, very early, really before a child is born. And these patients, many of them have quite low nephron numbers, and as they grow up, you may not actually know that their kidney function is compromised because their creatinine doesn't look too bad. And then they have the growth spurt, and then they go and live their lives as adults. Especially in women, they have huge stresses when they are pregnant, and we may find that they end up with kidneys that are very damaged, after they've given birth. There's also lots of environmental stresses that maybe we can do something about throughout the life to improve their kidney future. Every nephron matters. We've developed quite sophisticated ways of measuring nephron numbers. And as you can see, once you're born, it's downhill from then. When you're 90 years old, you've only got half the nephrons you were born with. And if you've got CACUT, you start off with a very low level. And as I said, maternal health really matters. If the mother before you're born has deficiency, then the nephron numbers is reduced even further. If you're born premature, if you have neonatal AKI, that really hammers the kidneys. In the Awaken study, we found that half of all infants less than 28 weeks have AKI, so there's a double whammy there. I'm just going to convince you over the next few slides about what CKD progression looks like, what the mortality in young adults are, what we can do to promote health, and maybe how genomics can throw up challenges for us. CKD progression begins in childhood. We have lots of patients that, they come there like, 16, 17, 18, their kidney, the creatinine looks quite normal. In Israel, everyone has to do military service when they're about 17 years old, and they've kept really good records. So these are 30-year data. If you have a history of CACUT, then actually 30 years later, your kidney function, a significant number of those go into end-stage kidney failure compared to normals. These are people with a history of acute. When they are looked at 17, there's no evidence of them having impaired kidney function. If you have a history of pyelonephritis, if you had glomerular disease, your risk of end-stage kidney disease significantly increases. Even persistent dipstick hematuria at age 17 increases the risk of end-stage kidney failure, even though all other markers look quite normal. Even mild childhood CKD can be progressive, especially if you had glomerular disease. So look at the, don't worry about the severe group. Look at the dark green ones. They are the ones who GFR is pretty good. There's no proteinuria, but look, 8-10 years later, many of them reach end stage. So this is from the ERA European Registry. So this is a skill group. These take adults who have reached end stage, and they look back at their progress. So firstly, not all CACUTs are the same. Some subgroups go into kidney failure quicker than others. The majority of these CACUT patients end up needing transplants in young adulthoods. This is when they're in their prime. The good thing is that when they do get transplanted, their grafts last longer, and the 10-year patient survival is better due to lower cardiovascular risk. There's still cardiovascular risk. And what about young adults who, what are their lives like if they have end-stage kidney failure? So this is 5-year mortality from children who are up to 12, 12 to 20, and up to 30. As you can see, the mortality actually increases a lot as young adults, maybe because of their disease, maybe because of their lifestyle behavior, and a lot of that is to do with cardiovascular risk though. So they're not the same. So this group is quite vulnerable, young adults. This is a big study in the UK, and obviously it's hard to compare different countries. So there's this study, 1,000 young adults aged 16 to 30, and they were asked, what are their lives like? Unfortunately, they're much less likely to be in a relationship, they're much less likely to have children, they're more likely to live at home, still in a family, and without a job. Their quality of life is poor, and many of them have psychological issues. But actually they're nice kids. Not many of them smoke, drink, or take drugs. And they're just nice kids. Increasingly, with longitudinal data, again, this is the Israeli study, maybe some of the urinary tract cancers are increased, and at a much younger age as well. And maybe that's to do from the ureteric genesis. Okay, so what can we do to prolong their kidney health? And you all know this. So, and I'm just going to show you some senatorial papers throughout the last many years. So this is the ESCAPE study, and essentially they're randomized into okay blood pressure. So these are not children with high blood pressure. Their blood pressure is less than 95th centile, or really sort of suppress them less than 50%. And look, both in the glomerulonephritis group and in the CACUT, you're buying them much more time with prolong their kidney life. So actually aiming for 50th centile is good for kidney survival. Similarly, this was just published, and I was very happy. I was very fortunate to be involved. A UK centre, and this is actually again looking at comparing blood pressure targets, but actually we're looking more at cardiovascular risk. And again, with the intensive group, we're finding so it's very hard to look at cardiovascular risk in children because they don't unlike adults, have heart attacks and so on. But what we can do is to use proxies, such as how thickened the heart is. And we can see that actually with over 5 years, with more intensive treatment, you're getting a better outcome in both groups. And I think one of you said before, if you're in a trial, you always do better, even if you're in a control group. We only showed any significance in wall thickness, but it was still very good. So really, we should aim for about 50th centile in blood pressure in the CKD population, and not just take not being high as okay. Obesity is an independent risk factor, and we've got, so this is a quite old study now, and it shows what happens to blood pressure with obesity. So firstly, this is the reference group. If you have normal BMI age 5 and then you become obese, your blood pressure goes up. However, if you were obese at age 5 but you became normal BMI at age 14, your blood pressure normalizes. So we should try to get children to have a normal BMI. But if you are both overweight at age 5 and 14, then you have a double whammy and your blood pressure is highest of all. We saw this before about nephron loss. And look, we don't have data on children, but this is on middle-aged people. Look at how steep this line is. If you have hypertension, your nephron loss accelerates. We know, and I said at the start, we may not think, someone with a GFR of 80 but solitary kidney is okay. This is a big study in Netherlands, and really their definition of kidney injury is proteinuria, having lower GFR, high blood pressure, or being antihypertensive. A solitary kidney, 75% of them have one of those factors. And the modifiable risk factor is high BMI. You saw this yesterday, and as I said before, really close working with urologists is very important. And we shouldn't accept children with recurrent urinary tract infections who've got CACUD. We should try to do something about it. Nearly at the end. So transition to adult services. So many of these young people, as I said, they feel well, they're not on many medication, but they need to protect their kidneys for the long term. In the where I work, we've got this program called Ready, Steady, Go, and it's really trying to educate the young people to take care of themselves. And we've got translations in many languages now. We don't have it in your language, so if anyone wants to help, please come and see me. And it's just a few pages going through things like, I'm confident in my knowledge about my condition and the management. I look after my own medication and where to get them from. So something quite simple to upskill the young person. So we've heard a lot the last couple of days about genomics. It can help in getting a diagnosis, but it also throws up some challenges for us as nephrologists. So in CACUT now, still a lot of genes are unknown, but increasingly this proportion of genes that we do know is getting bigger and bigger. The most common ones are PAX gene and HNF1 beta. Imagine if you do a panel, and this is the UK panel, so if I got a child with kidney disease, I just go down and see which one, and then I get a result in a few months' time. I heard that in India, you'll get a result in a few weeks. We're a bit slow. It takes 6 months in the UK. But imagine you come up with HNF1 beta, which is quite a common condition for CACUT, for this 15-year-old girl. It is also somewhat dominant condition, and 50% are de novo. And how it results in CACUT is that it interferes with embryogenesis of the referring duct, but also pancreas and liver. There's very poor genotype-phenotype correlation even within family. And if you go slightly beyond the gene, you can interfere with things like autism and schizophrenia gene. So there's some link there. And the pie graphs on the right shows that from the kidney side of things, it's completely random what you get in terms of what CACU you get, and also how bad the kidneys are affected. However, if you look on the person graph, they can get early diabetes. So, you've got this information that they've got HNF1 beta. We need to train up the families and the patient to actually look for diabetes. You may be the first to recognize that this patient has quite a high risk of having infertility because of genital tract malformation. So with this knowledge comes some responsibility about what do they need to know, and do we need to look elsewhere to look for other pathology, extrarenal manifestations. So really, how I conclude is that we've got this young lady, kidney function is not too bad, but her future will be best if she has some monitoring for life. We need to aim blood pressure, not just okay, but maybe about the 50th centile, needs to maintain normal weight, need to treat UTIs aggressively, need to look for extrarenal manifestations if you get a gene. Psychosocial support is critical, preemptive transplant when it comes to it, and something about good transition to adult colleagues and empower them to know more about their condition. However, on a wider point, I think we need to improve maternal health. Access to universal antenatal scans could help, and also we need better markers than just creatinine to look for early nephron mass. So I will leave you with that, and I hope that's been useful.
It's a nice and very elaborative description of a part which we commonly ignore. Specifically, we are the adult nephrologist to get a patient in a state of end-stage disease, probably not so looked over the years after resolving a childhood disease, maybe a congenital one, maybe an acquired one. So I have questions back. Suppose a patient is having not any congenital abnormalities, but resolving 1 or 2 episodes of UTIs in very childhood, or a patient having a post-streptococcal glomerulonephritis that is thought to be resolved. So is the glomerular disease are more dangerous or a tubular interstitial? How do we follow up over the years? You have told, but how do we follow up these patients till we get in the adulthood?
Yeah, I mean, it very much depends on what your healthcare service is like. But, they may not need to come to you for follow-up, but they need some kind of follow-up so that they don't develop occult high blood pressure, for example. Look at proteinuria. And I suppose a lot of it is about self-care. If they have episodes of glomerulonephritis, do they know that it may cause their kidneys to get worse? I would recommend, they to have annual screening, annual blood tests, etc. But it may not be possible.
So, how do we monitor this GFR over the time? Is the normal course it should increase with time? Is the estimation is better, or a calculation measurement is better? And which method do you recommend to monitor the GFR over the years?
Yeah, I think very much. If you've had kidney disease, which is pretty significant, or you're born with kidneys that aren't very good, then at the minimum, maybe annual GFR, annual blood pressure, and an annual proteinuria check. Does that answer your question? Sorry, I wasn't quite sure what you asked.
Do you just estimate the GFR using the formulas, or do you just recommend to do an yearly DTPS scan or a 24-hour creatinine clearance like that?
Yeah, really, you're looking for quite large shifts. And then I suppose what I'm trying to say is that what you don't want to do is to say, oh, everything's okay, you can go now, and not have any long-term monitoring. Because even in in my country, it's quite common for someone to say, oh, your creatinine is kind of okay, you know, you're now 15, 16, you don't need to see anyone ever again. And then 20 years later, they end up with end-stage kidney failure, very high blood pressure, and maybe, you know, things could have been done earlier to have slowed that decline down.
One of my patients has an acute kidney injury due to acute pyelonephritis. He is around 10, 12 years old. Now I have treated him, his kidney function recovered. Now should I tell him, hey, you have a one episode of acute kidney injury, now you have to come me from every 6 months for the follow-up. Should I tell him, hey, you are healthy, go back to your school, enjoy your life?
Yeah, I mean, I think it very much depends what your health service is like. But I think one episode of urine infection, as I said yesterday, what I suppose you don't want to do is to have that young person have another episode, but kind of think, oh, actually, it's not such a big deal. For those with, it's all about raising awareness that it is not okay to have episodes of hematuria. It's not okay to have too many episodes of urinary tract infections without, you know, them getting sorted out.
Hello. Sir, do you recommend screening of all school-going children for detection of proteinuria or hematuria?
No. Well, I mean, so there are some countries who do annual urine dipstick testing. So a one-off school entry dipstick testing. But those tend to be countries with quite high level. And it's very, you know, it costs a lot of money, and you may not know what to do with the results. So I think only in sort of Far East countries, Japan, Korea, and their results show actually if you haven't got a proteinuria, there probably isn't much a benefit, and you need to screen a lot of people to stop one episode of end-stage kidney failure. It's incredibly expensive.
Yes, Dr. Rajiv.
You're going to ask me a hard question there.
Did you cover about the call for mutations and all that? Because now the evidence has come up that even without proteinuria, if you are putting up these children on ACE inhibitors, then long-term outcome is better. So without ACE inhibitors, you will go into ESRD say as at one age, and with ACE inhibitors, even without proteinuria, you will go to ESRD at a longer age.
Yeah, I think it's very hard for us in tertiary care to actually influence, to actually say what one should do with mass screening, especially if there's no first-degree relative with hematuria syndromes or Alport syndrome, because it can end up being very expensive for the healthcare system.
So don't you think that's what I think, that at least if you get a child with microscopic hematuria, at least the initial investigation, at least the parents should be screened and this child should be screened for 2-3 times at least.
Yeah, correct. So I think if you have macroscopic hematuria, that's different. But if you have microscopic hematuria...
No, microscopic. I'm saying microscopic.
Oh yeah, if you have a microscopic hematuria, if it's a one-off, then it does need to be checked to see if it goes away. And then if there's no family history, then you get in a situation where so there has been quite a lot of studies that show the yield of looking for something is actually very low. So you can spend a lot of money.
But the studies were before the genetic era, sorry.
Yeah.
They were before the genetic era, so is it changing?
I think we need some economic analysis.
Can you put the child on SGLT inhibitor for reducing the progression of CKD?
Sorry?
SGLT inhibitor, emegliflozin, for putting the child on SGPT-LT inhibitor for reduce the progression of CKD.
So sorry, I can't hear about. Yeah. Ah, right. Maybe I'm not the best person because I've never had any experience of using that. But perhaps in the future that will come into the pathway. But I think at the moment we're a few steps away from that.
Have any question? We conclude the session. Thank you very much.
Great. Well, thank you very much. It's been a delight.
Dr. C for this excellent lecture. And like we all save our best for the last, so moving on to our last session, the most interesting one by Dr. Professor Vivekanand Jha, a very decorated speaker. For this, I'd like to call upon the chairpersons, Dr. Ashwini Gupta. Sir is a senior consultant nephrologist at Sad Gangaram Hospital. Dr. Jyoti Prakash, a professor and HOD Department of General Medicine, AIMS Patna. Dr. Preetpal Singh, additional professor, Department of Nephrology at IGIMS Patna. And Dr. Dharmender Prasad, consultant nephrologist at Prasad Hospital, Mumbai, Prasad Hospital, Muzaffarpur. To introduce the speaker and the topic, transforming kidney care with artificial intelligence.
Good afternoon. It's a great privilege for me to introduce Professor Vivekanand Jha for this concluding talk of this wonderful CME organized by a dynamic team of Professor Hemant Kumar, Om Kumar, and all the stalwarts of Bihar. Professor Jha, a very dear friend with whom I have an association for over 4 decades, is a wonderful human being with lot of values, a great teacher, loved by his students and mentor to many. And he is an academician and researcher par excellence with more than 300 papers. And above all, I would say that I have seen many people going abroad, they don't come back. He has not only come back to India, but he has brought back global health care India to New Delhi. And presently he is the executive director of George Institute of Global Health. And he is the chair of Global Health and Kidney. And he is a professor of medicine at Imperial College of London, conjoint professor of medicine at New South Wales University, and he has been instrumental in setting up a tissue culture lab at PGI Chandigarh. And he is the first Indian and probably the first Asian to become president of International Society of Nephrology. So with these few words, I would invite Professor Jha to deliver his talk on transforming kidney care with artificial intelligence. Professor Jha, please.
Thank you, Ashwini. As usual, you are, being a dear friend, you are very kind and over generous with your praise and sort of spoil people when it comes to that. But let me also start by expressing my deep gratitude to Dr. Hemant Kumar, Dr. Om Kumar, and all the colleagues of Patliputra National Kidney Foundation and the Bihar nephrology community, which I can say with great pleasure that it has grown and it's become very, very strong now. So the job that Hemant has given me is somewhat different from the kind of talks that you've heard over the last couple of days. And he wants me to talk about big data and artificial intelligence, which are all big buzzwords, but we need to understand them if we are going to be in a position to make the most optimal use of all of these various technologies that are becoming available to us. Just like all new technologies, they have the potential to do a lot of good, but they can also lead us astray at times. And so unless we know how to harness them properly for our benefit, we can easily go in the direction that is not necessarily one that leads us to a good place. So before we get into the discussion of the topic, let's just try to clarify a few terms. And the first question is often asked, what are big data? Is it something that can be defined in numbers, or is it something that can be defined by some other dimension of size. So the answer to that is that it's all of those, but still none of those. These are large, complex data sets that cannot be managed using traditional software or internet-based platforms. That's the easiest way of identifying what big data is. So when you have the kind of data and the kind of analysis that you want to do cannot be done using traditional tools that we have available. And they often surpass the traditionally used amount of storage, processing, and analytical powers. So we are now having to develop new terms like petabytes. We all know gigabytes, but petabytes, yottabytes, and terabytes, and so on and so forth. And therefore, they require high-end computing solutions for managing them. There are a few qualities that big data are thought to have, and they all start with the word V, which is incidentally the first letter in my name as well. They are, of course, large in terms of volume. They also are varied. So variety is important quality of big data. Velocity, they're produced very rapidly. For example, those who run dialysis units, they know that dialysis machines produce a lot of data, almost on a minute-by-minute basis. And they are data related to procedure, data related to patient, etc. But importantly, they need to be of value to us. If they are not of value to us, then it doesn't matter how big the data is. And therefore, for them to be of value, their veracity needs to be proven. That yes, we know that they're good, clean data, and they are able to do the kind of things that we want. And big data is critical to the optimal use of artificial intelligence, to which we'll come in a moment. But the main sources of big data in kidney health community is electronic health records that we are all using more and more. They are more in use in some healthcare systems like the ones that Dr. Vincent comes from, or my friend sitting here, Dr. Tobias, working in the UK, also comes from. But we are hoping that they will become more ubiquitous in India as well. Billing and insurance claims are an important source of data. But then data are also generated through national programs like population surveys, surveillance systems, census, etc. An increasing number of disease registries and databases are being set up. If you are a researcher, you perhaps have participated in a cohort study or a clinical trial. We all do now laboratory tests, and multiplexing of laboratory tests has become very common. For example, now you send off panels, right? As Dr. Tsay spoke about, and various kinds of panels that depends on the phenotype of the patient that you use. But also other type of tests. I'm sure you are now sending out tests. If a patient is admitted to intensive care unit with fever, then you perhaps just send out a panel of tests which perform DNA diagnosis of infections. And we have all of these devices that we wear. Mine is a simple one, but I'm sure many of you are wearing iWatches, Apple Watches, which will generate complex amount of large volume data almost on a daily basis, or almost on a monthly basis, or weekly, even minute by minute. So if we just break the data elements down, they can be of basically three types. There could be very structured data, so you know exactly what is the heading and what is the data that you're going to get in that box. For example, systolic blood pressure, diastolic blood pressure, age, sex. Similarly, you go on. So these are clinical data or electronic medical records. Then there are some semi-structured data. They're not structured so well, and these are claims data. For example, an insurance you might file a claim to your insurance company, or a hospital files claims to the government for the services it has provided. So there is a bit of a mix of data, and so it is not as well structured. And then lab reports also can come in semi-structured form. Then finally, we have totally unstructured data. For example, an X-ray image, right? There is no structure to it, but the software has to derive a structure out of it. We have biopsy images. We have clinical notes. Notes are written by humans in their scroll, and then images have to figure out what to make out of those notes for them to be used in an artificial intelligence algorithm. And once that data has been collected, they need to be curated. So someone needs to do it. It could be a human or it could be a machine. What is the purpose of curation, you will ask? Curation ensures that the data is accurate, it is consistent, it is credible, and it is also timely. You don't necessarily want to use the data which which has been produced in a time period which is different from your time frame, right? And we also want to make sure that the data that we have are of high value for any kind of analytics that we want to do. There is a principle that has, and the principles have been developed for curation of data, and they are known by this acronym called FAIR. What is FAIR? The data should be findable, the data should be accessible, it should be interoperable, which means that if it is generated in one platform, it can be used on another platform as well. There was a day when then the Apple world and the PC world was different. Something that you used in a PC could not be used on an Apple device. That is not what we want here. We want, that's just a very crude example I'm giving you, but then operability can be a concern even with softwares. Many softwares don't talk to each other. And finally, they should be reusable. This is just a figure here to give you a sense of the complexity of how do we do this kind of analysis if we are going to be able to use artificial intelligence algorithms. So we get data from a range of sources which are shown here on the left. It goes to data warehouse, and the data warehouse has this, what for us humans or us doctors is a kind of black box. And within that black box, analytics is going on all the time, looking at just describing the data, deriving diagnostic features out of it, trying to develop predictive models, and finally using all of them to come out with some prescriptions, right? And the first 4 set of processes give you an insight into the data, but the prescriptive one will give you some foresight as well. And what we want as doctors or healthcare professionals is improved outcomes by development of smarter and cost-effective decisions. Something similar is just said in a different way here on this slide. We do use big data and artificial intelligence for diagnostics, but very importantly for preventive aspects. Some wise man said that the best hospital is the hospital that doesn't need to be built because we were able to prevent a disease, right? So you don't need hospitals because you have prevented that disease. So we use this data and we use this as a mix, like I said, and you heard the talk on genetics here. Genetic, lifestyle, and social circumstances, these are all important for disease prevention. We often talk about precision medicine, and precision medicine is not possible at all without big data, artificial intelligence. We are always constantly engaged in research, and the research also needs to be informed by these approaches so that its efficiency can get better. We can reduce waste, we can minimize harm, and we can come out with the best type of solutions. Reduction of adverse medication effects, something very, very important which we don't pay attention to. We are engaged as kidney doctors in polypharmacy almost on a hour-by-hour basis. Many of you are very busy clinicians. I'm sure you see scores of patients in your clinic every day, and you use, I'm sure, 8 to 10 medications in every prescription. It is impossible for you to remember which drugs interacts with which, or which drug has what kind of side effect at what GFR. And it is here that the predictive algorithms come into play, and they tell us, they warn us. And if we use an electronic prescription system, and if you have done something, you will see a pop-up warning you of possible things that can go wrong with this, and in the end, population health. So again, if you had to remember a few opportunities where we can innovate and improve healthcare through development of data-driven applications in clinical practice, but also in research, these will be a few things. Early disease prediction by identifying those who are at risk. So why this is important? Because when you identify someone who is at risk, you can appropriately target interventions or therapies. You don't want to treat every single individual in the room to prevent diseases that might develop only in 10% or 20% of people. So appropriate prediction is important. Then of course you want to go on and make a diagnosis in a timely manner, and diagnosis of a few conditions like the type that Dr. again Vincent spoke about and were discussed even earlier, like CT glomerulopathy and all of that. It's not easy to make those diagnoses. And so those diagnoses do require support, and we'll come to that in a little bit how it can be done. And then data-driven treatment decisions. And finally, research. I come back to research all the time because research is something without which we cannot make progress. So How can the health systems learn by using artificial intelligence? So you have the health problem that interests you or interests a population or interests another stakeholder. It could be a policymaker. A government official can come to you and say, find me a solution to X. So that is the health problem of interest, right? So you start with data. You start with data on the left. Data needs to be used to generate knowledge and also to understand what are the gaps in care. There can be gaps in the care of an individual patient or there can be gaps in the care of a population, right? And then we take that knowledge and convert that into practice. You know, I'm not going to read all the small text, but you can read it yourself. And then in this, it is here where AI comes into play. Because then AI can be used to allocate appropriate resources to high-risk individuals so that those who are most in need are served more than others, and to prevent unnecessary interventions in low-risk patients. I keep coming back to it, and this is the answer to Dr. Rajiv Sinha's question, is that you don't want to just dump something onto the entire population, right? Just because someone has had microscopic hematuria in the family doesn't mean that now you gave ACE inhibitors to everyone in the family. So you have to basically target the interventions. And then using this approach, if once we sort of internalize this approach, we form what is called a learning community. The community is prepared to learn, entire community. And then they are working together to solve problems of interest. And finally, once we have changed our practice, this practice also needs the generation of more data. But this data is somewhat refined, it is somewhat different, and that new set of data once again enters the same cycle, and thereby the learning healthcare system continues to improve over the period of time. Right? So now let's dissect out this issue of artificial intelligence a little more. And there are two other terms that I want to introduce here, which is machine learning and deep learning. These are two important terms which are essential for artificial intelligence understanding. So machine learning is, if you have some data, you can teach a machine to analyze it. So this is called kind of supervised learning. You supervise this, and you give that set of data, but you also tell the machine what these data are, and what do you want to get out of it, and so on and so forth. So that's machine learning, which can be supervised. But then after some time, our hope is, and also that's a big worry, that the machines can perhaps learn to understand data by themselves. They don't require any supervision, right? So that is unsupervised learning, or deep learning. And that is a bit scary also, because you don't know in what direction it is going to go, and this kind of conversation is starting to take place. I don't know if you follow the news or not, but over the last 3-4 months, the news about ChatGPT and new artificial intelligence algorithms and what it can do. There was a very nice, I shouldn't say nice, but very interesting feature that came out of a reporter from the New York Times having had a conversation with Bing, which is a search engine like Google, right? And the search engine was responding to that person's question, and some of the responses were scary to him, right? Because the search engine said, I want to end the population, or something like that, you know, something crazy like that. And so, whereas it can do good, it can do harm also. So now, having talked about that in a general sense, let's come back to our field of kidney disease. Where can we use artificial intelligence in kidney disease? We can use that to identify acute kidney injury early, which is where it's being most used, I think, right now of all the kidney conditions. But also in CKD, to identify CKD, predict progression, in dialysis for management of various medical problems that patients on dialysis have. Kidney transplantation, prediction of graft rejection is the holy grail, right? We always want to be able to tell right away which patient is likely to develop rejection or other kind of complications, and therefore optimizing immunosuppressive therapy. Analysis of images in nephropathology, kidney biopsies, there is always a struggle. Where do you find a good nepropathologist? That's not easy. And if machines can help us, that is something which we can really welcome, right? So if you look at this in a conceptual framework, according to this paper that came out by Azra Bihorak, who is one of the leading researchers in artificial intelligence in the kidney field, you can get data from, again, multiple sources. They can be omics data, genomics, genetics, but also microbiome is something, or metabolomic data that is being generated. You combine it with clinical records, and clinical records again can come from many sources. They can be previous records, you can get demographic information, biopsy samples, physical status, ultrasound, etc. And then patients are generating health data all the time through sensors, smartphones, watches. They use point of care devices. You have your blood pressure instrument which can store data. You have continuous glucose monitors, and patients will report symptoms also. So patient reported symptoms, PROMs, etc. are also very important. And then there are a few methodological issues which you don't have to necessarily worry about. There is classification, and this is where machines will come, right? The machines will figure out what are the endotypes using the omics data. They will classify and cluster the clinical data, and they will use that for reinforcement learning, and patient-generated health data also gets into it. And in the end, what we are looking for is the panel at the bottom. You want to be this machine to be by itself identify conditions like AKD, AKI, CKD, etc., and what are the optimal treatments. So wouldn't it be great if you didn't have to think and the machine just spat out a piece of paper which told you this is how you need to treat this patient, right? And of course monitor symptom-based recovery. Let's just focus a bit on AKI and artificial intelligence. As I said, AI is being used right now most in AKI. So Google DeepMind, which is one of the potential big threats or something that can really disrupt human life in future, was used to develop a continuous prediction model of acute kidney injury in the US veterans, in the Veterans Administration healthcare system. And what the researchers did is that they took the AKI-based models to predict stage 2 AKI 41 hours before a rise in serum creatinine was observed, and they were able to predict a need for dialysis within 2 days, including in those who had pre-existing CKD as well. And what the EHR-based model did is shown here in the third bullet point, really, but the artificial intelligence performance was better than this. And in the end, they were able to achieve a reduced time to AKI diagnosis in adults with a number of predisposing conditions like burns, acute pancreatitis, post-op situations, cardiac disorders, etc. And using that, they have now, again, this is a bit fuzzy, and I don't think you can read it, but you can go to this paper published in the Journal of Medical Internet Research, which tells you what would be a potential pathway of when a test is ordered. On the left side, when a result becomes available, the results is obviously all the results need to be validated by someone, and so that means that the AKI is detected. That will be the first alarm that goes out. And once that alarm goes out, a pathway sets into motion, which involves technicians calling to the ward, a junior doctor getting informed, and the junior doctor deciding whether or not to page a specialist, etc. So that is the standard pathway. And here you can see what is there in the bottom. That is the top pathway, right? That's how it happens right now. But there is a fair amount of work which is still remaining. And I'm sorry that the contrast is not great on the screen. It looks well on the computer screen here. And the question that we need to ask is, are these tools reproducible? Can they work in all healthcare systems rather than only the ones where they have been developed? Do they improve meaningful patient-centered outcomes? You can do, and you can show that you could detect AKI 6 hours before they could be detected in using a traditional methods, but does it really do anything good to the patient? Otherwise, we can spend a lot of money and still the patient is in the same place. They all require external validation, and they require development, and in the end, the holy grail is that we should be able to identify a potential intervention that is influenced by whatever new methodology we are using, and that potential intervention should lead to improved outcomes. So these are the kind of things which can be informed only by randomized clinical trials. So here is the study which involved more than 6,000 adult patients. So this was a double-blind study, randomized control trial, in which electronic health record-based pop-up alerts for acute kidney injury were investigated. And they were actually not able to demonstrate any improvement in the composite endpoint of acute kidney injury progression, receipt of dialysis, or death within 14 days. So even though it looks good, it looks good and shiny, you are getting something automated and everyone is excited, but ultimately it didn't do any good to the patients, right? So the American Society of Nephrology has started this initiative called AKI Now, in which they are going to test artificial intelligence effort for quality improvement in acute kidney injury. If you are interested, the website URL is shown at the bottom, which is at www.asn-online.org/AKI Now. What is of more immediate relevance to us is possibly this artificial intelligence based decision support system. What is a decision support system? It's a computerized program which is used to support determinations, judgments and courses of action in an organization, in a business, in a healthcare setting. So this is the typical CDSS or decision support system, clinical decision support system workflow. That again, data comes from various sources which you have already talked about. It is stored, it is shared, it is integrated, it is analyzed, and it leads to a clinical decision supports. For example, here the computer will analyze, here is a patient who had hypertension, he has a urine albumin creatinine ratio of more than 300, therefore this patient should receive ACE inhibitor. And the computer will automatically check whether there are any contraindications to the use of ACE inhibitors, or are there any drugs that are interacting, is the kidney function of the patient good enough or not, and then it simply gives you an output, you don't have to think more about it. And again, there is an AI life cycle for decision support also, like the life cycle that I showed you earlier, that we again start with data extraction and processing, undertake evaluation, tune parameters, and perform an explainability analysis. This is really important because whatever we do should be biologically plausible. For example, there should be, and we understand that lower GFR and higher blood pressure are associated with bad outcome like increased risk of chronic kidney disease. So once this is explained, then we train this model, we perform external validation, and we go back to the point of fair data principles. So we perform the fairness evaluation, right? And then we go ahead and then do clinical implementation. After we have implemented it, we validate it prospectively and once again get into it. So having said all of this, it will be remiss on my part not to identify possible challenges to these big data artificial intelligence projects. There is still concern, especially in systems that are still developing, about data volume, ownership, who owns the data. Does the patient own the data? Does the healthcare system own the data? Does the insurance company own the data? It's a big issue. We don't think about it, but these are big issues. Here we write prescription and we just hand it out to the patient. After that, the patient is on his or her own. They have to go to the chemist and figure it out for themselves, or they go to the lab. There is heterogeneity, analytic approaches are also not uniform. These data are fragmented. These data are fragmented and databases are even segregated as well. Data are inconsistent, there can be missing elements, and we have to identify and correct those missing elements. We need to have the right kind of infrastructure, and we need to make sure, as I said a little bit earlier, that the operability doesn't come into play. So, again, just going more or less in the same vein, we need to strengthen our data governance policies and frameworks. We need to have good data protection laws. We need to ensure that the proprietary rights are equitable among stakeholders. There is consistent funding for this. And often there is reluctance with the medical community also, who is just used to working in a traditional way. And for building this kind of artificial intelligence competent workforce, we need to have people who understand computer science. They need to, it's my belief that if there are two things that we need to teach our medical graduates even before they start MBBS training. One is mathematics, so that they understand basic principles of data management and uncertainty. And second is they need to understand some degree of liberal arts and human knowledge. So we do leave people who have the nephrology domain knowledge, but the other type of domains are completely missing in our healthcare system. So therefore, often the question is asked, is a computer superior to humans? The answer to that, of course, is not at this point. But if you have a human intelligence, combine it with use of computers or artificial intelligence and apply scientific methods, you will end up with humans who have bigger brains or more knowledge, And in the end, what we are looking for is a computer system or a data system which typically has narrow intelligence. It is good at identifying trends and making predictions using those trends. It has indefinite memory and it can identify patterns. And if we apply that and combine it with scientific methods, then you will have hopefully something with wider intelligence, which is what our humans are. So you have your baby who's even 2 months old, so you can imagine sometimes how much intelligence they have, but they are immediately able to identify who are their parents, grandparents, their toys, etc. If you give that to a computer, the computer will not be able to do it. The computer has to be trained a lot in order for that to be identifying individuals, right? There are a number of enablers. Thankfully, we are getting there. We have devices, sensors, wearables. We have digital therapeutics now, nutrition trackers. Personalized healthcare is becoming more ubiquitous, like these decision support systems. Telehealth is something we became very familiar with during the COVID pandemic, remote patient monitoring, care, etc. And we are using more and more health technology. But before we go, something which is really topical is the use of these healthcare chatbots. I don't know if any of you have ever been confronted by your patients. So what are these healthcare chatbots? You will ask the question. So these are automated tools which are designed to simulate an intelligent conversation with human users. You have used IVRS, right? You call your bank and you get some prompts. Dial 1 for this or 2 for that and so on and so forth. This is a much more refined version of that. And during COVID, this was used. So this is a platform called COVID Asha platform. And these healthcare chatbots, I won't go into details because we have already run out of time. You've heard the bell. But these kind of chatbots are potentially going to be useful in a number of places. And these are 5 potential what are called use cases, that this is where we can use them for providing informational support, scheduling appointments, collecting patient information, providing medical assistance, and assistance in refilling prescriptions, which is something which we don't do here in India because our patient just goes to a chemist shop and buys these things. Therefore, my dear friends, in conclusion, big data can provide key information about disease burden, mechanisms, risk factors, etc. But when we combine artificial intelligence and machine learning, it can be used for early diagnosis, prognosis, clinical decision support, etc. Data curation is important. Bad data in, bad result out. We need to standardize it. We need to make sure they're interoperable. They can be consolidated and exchanged. Very, very important. We are all hoarders of data. We keep our data to ourselves and we nurture it even closer than some of the valuables that our family has. It's important that we share data. Only then can this field improve. There is a large-scale acquisition of annotated data. There are going to be advances in machine learning. Open source computational packages are becoming more and more available. That is affordable. So your smartphone now has more computing power than the computer that I started using it when the first computer that I used in the 1990s. But then there are a number of challenges also, but we've discussed some of those challenges, so I won't repeat it. And we need to, as a community, address those challenges if we have to get the most benefit out of the artificial intelligence and machine learning and big data promise that is there in front of us. Thank you very much for your attention. I apologize for running over time.
Thank you, sir, for your nice delivering the lecture on a new topic of artificial intelligence. We must have definite role for clinicians and even researchers in the field of treatment of nephrology. So I think it will help us a great in diagnosis, management, and also in the prognosis of the disease. And I just
definitely this is a leap forward, but with a caution on how they will behave, their policies, and definitely, as you said, ethical issues need to be taken care of. So now House is open for these suggestions or any comment.
My question is, the chat GPT is freely available now as a software, and people have started citing it in scientific journals. So your comments about the ethical aspects and the ramifications of it, if somebody uses it for scientific writing.
Right. Thanks. That's a very important question. Chat GPT, I don't know how many of you are aware of it. I'm sure many will be. And the answer to your question is not easy because this is hotly being debated in the scientific community right now. can ChatGPT be added as an author to scientific publications? I have used ChatGPT, and sometimes you are really amazed, impressed, and sometimes scared by the kind of outputs that you get, because they're so good in many ways, right? So, should they be credited as authors? I think the community will eventually decide, because the decision has to be something of a consensus that everyone buys into. It won't work if 4 journals accept it and 10 journals don't, or funding agencies. So it takes me back to this particular slide. This is what ChatGPT for me is at the bottom. You can get something out of ChatGPT, but you have to apply your own brain to it. You have to understand what it is trying to say. If you combine it with your own intelligence, then perhaps you will get the most value out of it, right? But it is a huge enabler. But like I said, going by the experience that was reported by the New York Times writer, it can be scary also. And actually, after that report came out, Bing has taken its GPT-enabled search engine offline right now. So ChatGPT is available, but it's work in progress. It is there. It's not going to go away for sure. And just because the ChatGPT decided to release its product, Google and Microsoft, they sort of had to rush in and come out with something. And therefore, the Bing product, which is the Microsoft product, turned out to be perhaps not optimal. And so they've taken it off. It will come back, and it will come back as hopefully something better. We need to know how to use it. So I think we live in a world where you can't afford to be a Luddite. You have to you have to learn to use technology. If you're not going to use technology, not only will you be left back, you'll be perhaps trampled over also by people who are going to run over you. Not only because they will get to a faster place, but you will just not be equipped appropriately to manage even your own daily work, because your work would have changed by that time.
Thank you, sir. Thank you.
Thank you very much, sir, for this excellent presentation. Can I take a minute?
Dr. Urmila.
So actually, I tried again ChatGPT. It's now coming with a disclaimer that I'm not supposed to do this and all those things. And we still downloaded a report. If you do a plaque check, you don't cut across, because ChatGPT takes things from many places. If you improve your plagiarism check, the article fails in journals.
Yeah, so
we have to find out ways not to.
Yeah, there are ways to detect which chunk of text has been generated by an artificial intelligence algorithm,
Yes,
or whether it has been written by a human. So there are ways of doing it. But the point is not to say that ChatGPT is a bad thing. ChatGPT is a good thing. And these kind of algorithms are good. We have to know how to use them. For example, once you get senior enough, you use a junior colleague to do the research for you. So ChatGPT is your junior colleague. It is doing it for you. If you mindlessly just let it go out under your name, you are the one who are going to receive the blowback. It's more or less the same thing. So look at what the output ChatGPT gives you, and then you decide what you want to do with it. You may just decide to junk it, or you may decide to use just a portion of it, or it gives you some insights which you want to then follow up on and perhaps go to the kind of rabbit holes that you don't have time to otherwise find for yourself.
Thank you, Professor Vivekanand Jha, for a very, very thought-provoking lecture. And message is computer, brain, and scientific knowledge. And you should know how to use the technology. I think that will be the best way of summing your wonderful lecture. Thank you so much.
May I ask Dr. Jha one question, please? I just wanted to, it's not now for the last 10, 20, 15 years, there has been a great advancement in robotics as regard to surgery. It's not only the Da Vinci system, there are other systems that have come in, and using artificial intelligence in a very, very, very nice manner where they're trying to
I'm sorry to
impart.
interrupt, sir, but if you can get to your question because I have to catch a flight. So if you
No,
can
no,
get to
no,
your
no.
question quicker, I will be able to answer it.
The question is that, there are certain implications of artificial intelligence used in medicine, and using the robots is one of them. So I want to imply that your talk definitely was very, very, a great amount of wisdom, but artificial intelligence has to come in, in medical, in medicine in a big way in the coming years.
Oh, I can 100%, I can only agree with you 100%.
Excellent lecture. We come to the end of the academic session of this scientific extravaganza. And now I invite Dr. Professor Om Kumar sir for a few words before closure of the session.
So, thank you very much. You all will agree that we had a very good 2 days of academic feast. And for this, we congratulate especially Professor Hemant Kumar, the Chairman of Organizing Committee, and President Patliputra Kidney Foundation. I am very thankful to all the speakers, the faculties, chairpersons, and the delegates present in this hall. We thoroughly enjoyed your presence, all the support staffs, and if we have erred anywhere in providing hospitality and providing anything to us, kindly forgive us, and we look forward to meeting you in future for such programs again. Thank you very much. Thank you very much. Thank you very much. If lunch is ready for all the delegates and faculties, and if anyone from the audience wants to speak anything, they are welcome. Briefly, Dr. D.S. Ray. Professor R.M. Srivastav, sir.
So once again, I express my deep gratitude to the Zone ISN for this program and your very kind hospitality. This indeed was a unique experience. I was a landmark meeting here, and I hope this will be repeated in future also. I again urge my colleagues here to support pediatric nephrologists, either in practice or in the medical schools, medical departments, to encourage them to set up, just to encourage them somehow to come to you and take your help in this. I've been trying to do this to our own people, but there is some hesitation. I hope this will be overcome, and there will be more cooperation there. I think we have a lot to learn from you, both ways probably. There are a number of problems which we have, and we need your help to solve them. Again, my deep gratitude and thanks.
Dr. Hemant Kumar, Dr. Om Kumar, and all the people who are involved in this. We all enjoyed very good hospitality. Think of the hospitality you provide, and content and good choice of speakers. So it has made it very successful. Thank you for that.
कीजिएगा सर